Right, so this is scenario number 1. Our patient name is Miss Brown. And the scenario sounds something in between the lines of you are the psychiatry trainee on call. Your medical colleagues from the emergency services have asked you to help assess a 45-year-old female who has just been transferred to their service via the ambulance. You have been informed that she tried to burn herself alive in her backyard, but her neighbors noticed it and called the police. You have been told that she has been vocalizing to the medical doctors that she thinks she's already dead and does not want them to do anything for her. Your medical colleagues have done the necessary blood investigations and have deemed her to be medically stable. And the task is, please find out more about the abnormal beliefs the patient has and also perform an appropriate risk assessment, pertaining to suicide, like thoughts, active plans, protecting factors, and the same with self-harm, and possibly, I would say, I would add to this scenario, possibly with harm to others, although it's quite unlikely given the scenario, unlikely to have direct thoughts to harm others. Right. So if you can all turn off your cameras for the time being. Right, so if we can have Miss Brown. Hello. Hello, my name is Călin. I'm one of the psychiatry trainees on call. How should I call you?
There's no point in calling me anything. I'm dead.
Okay, I'm sorry to hear that. It does sound like things have been difficult for you lately. Can you tell me more about what has happened?
It's not important.
How long have you been feeling this way?
A few months.
A few months. Okay. And what happened a few months ago?
My son died.
I'm sorry to hear that. How your son's death made you feel?
I'm not sure. I don't feel anything anymore.
Okay. My understanding from my medical colleagues was that you're trying to burn yourself alive in the backyard today. Could you tell me more about what happened?
My body is rotting.
Your body is rotting.
Yes.
All right. Is it your entire body or a specific part of your body?
entire body.
Okay.
My organs are missing.
Okay. How can you be alive if your organs are missing?
I just can't.
Do you think that you are alive or dead?
Dead.
Okay. And for how long have you been feeling this way?
I told you.
So for 3 months since your son died then. Okay. But can you tell me then more about how things have been for you before you died?
They've been hard.
Okay. And with all this going on, how is your mood?
Can't quite tell. I forget things. I don't think I have a mood.
Okay. So if I would ask you to rate your mood from 1 to 10, where would you be today? 1 being the lowest, 10 being the highest.
1.
1. Okay. And have you been able to enjoy things you used to enjoy in the past, as of lately?
No.
What about sleeping? Have you had any problems sleeping?
I don't remember falling asleep.
So in the last 2 days, did you manage to have any sleep at all?
I don't remember. I don't think so.
What about eating? Are you able to eat?
No.
No. Okay. And I was wondering, you mentioned that you think that your body is rotten and that you have no organs at all. I was wondering if there could be an alternative explanation for all this.
No. I saw an angel.
Okay.
And then
Is this a reason?
that
Sorry, go on.
I knew that I was dead.
Did anything else happen to you that led you to believe so, or just this encounter with an angel?
I just know.
Okay. Okay. And when you say about seeing an angel, do you think you saw this angel while you were asleep or awake?
I was awake.
You were awake. Right. Have you been bothered by any unusual experiences, like seeing things that shouldn't be here or hearing any voices?
Yes.
Both or just seeing things?
Seeing things.
Okay. What other things have you been seeing apart from this angel?
I see my son.
Do you see him often?
No.
And is this distressing to you?
It doesn't feel in any particular way.
Okay.
It just feels
Have
like
you
I'm
been-
supposed to be with him.
Okay. Have you been able to communicate verbally with him?
No.
No. Okay. And do you feel that your thoughts are being interfered with?
I can't hear you.
Sorry, can you repeat that, please?
I can't hear you.
You can't hear me.
No.
Okay. So then how can we have this conversation?
You are talking to my soul.
Okay. Right. It seems like this is an extremely difficult time for you. And I wonder what were your intentions when you tried to burn yourself today?
I wanted to get rid of my body since it's rotting.
Okay. And how did you do it?
What?
How did you set yourself alight?
I used matches
Okay.
and clothes.
And do you still have thoughts of ending your life right now?
Yes.
Okay. What plans would you have? Would you try to burn yourself again, or would you try to do something different?
Burn myself inside this time.
Would there be anything stopping you from doing it?
No.
No. Okay. Is there any possibility that you might feel unwell because of what happened with your son?
I don't know.
Do you think you need you need help from a psychiatrist?
No, I don't need help from anyone.
So if I were to say to you that you need help and you would need admission to a mental health hospital, would you agree with that?
No.
No. Okay. Okay. Thank you, Ms. Brown, for your time. I'll be discussing the plan with my consultant, and I'll come back to you as soon as possible. Thanks. Yeah, I think we can come all back. So what did you think about it? I thought I'll do this patient just because it's a very difficult type of patient. I would have a very difficult time myself in real life, and I'll have to admit that even if I saw this, even if I knew the scenario and rehearsed it with Ioana and Miss Brown, you'll see who's Miss Brown later, I still found it difficult just because you would encounter a patient who is not willing to engage with you. So what do you think about it?
I think it was a pretty difficult case. I wouldn't know how to approach it, perhaps.
Yeah.
And I think it was hard to motivate her to accept help from a doctor or anyone at all.
Yeah, probably in a real life scenario, I think this was a very short one. At least in the UK, I don't know what happens in Romania. I'll have to admit, because I left Romania immediately after I graduated med school. So I did my entire psychiatry training in the UK. I had little to no contact with psychiatric services in Romania. However, this kind of interview in an INE situation probably lasts around 30 to 40 minutes. So I'll probably go into more detail and be a bit more empathetic with her than I was now, give her a bit more time to speak about what's going on. Although she'll probably not engage. I went a bit further than the last 2 or 3 questions. What would I do in a real case more than the task? Because basically the task said to explore her beliefs and to do the risk assessment, so suicidality and self-harm. This is a very interesting case. So this is depression with psychotic symptoms. What was she presenting with? So her belief that she is dead and that her body is rotting. It's called nihilistic delusions. That's a very specific symptom of severe depression with psychotic symptoms. Obviously, she would need in a real case scenario an inpatient admission. I chose this scenario initially because it's quite interesting to see this kind of patient, and you might see it in an INE situation after a suicidal attempt, or as a medical doctor, or on the toxicology ward. And it's good to know that you need to try and engage them, even though they are very hard to engage. And you might ask them 10 questions before they would even answer one. and try to be empathetic with them. Right. That being said, let's go to the next one. I promise you the others are easier than this. That's why I chose to do this. So team number 1, I'll share my screen and I'll show you the scenario. Right, so this is scenario number 2. Name of the patient is Stephanie. She was referred by her GP to the mental health team for excessive hand washing. And your task is to speak with her and obtain a detailed history and try to arrive at her diagnosis. This is basically the scenario. Do you have any questions? Should we start? If you want to discuss between yourselves, we can put you in a breakout room. If you find that helpful, we can do that. I don't know if that's helpful for you or not. For you too, I mean, if you want to have like a separate discussion about this case.
Yeah, I would like to.
All right. Okay. So I'll put Ioana, can you put them into a breakout room so they could discuss between themselves? You have like 2 or 3 minutes to do that. Okay.
Yes.
Thank you.
And I would also like to know if there's any point to ask Stephanie about her mood or something like that.
Usually it has a point in asking them. I ask them all, but go into the scenario and see how it goes. Your task is to try to obtain a history and to see if you can arrive at a diagnosis. So see how this scenario goes.
You want me to call you?
Stephanie is just fine, thank you.
You know here.
Sorry?
You know why you are here?
Yes, yes, I do. It's because of my urge to wash my hands, which I hope we can find a solution to.
Yes. That's, can you tell me when did you start to do that?
Well, it all started 6 months ago when I had this incident at work, but I mean, there was this chemical leakage at the laboratory where I work, and it can be very dangerous, but at the same time, you never really think that it can happen. You know, it's kind of like an earthquake, like it can happen anytime, but then again, it never does, but this time it did. And we were all lucky enough to not get hurt. The days after the incident were all right, but the weeks after it, I started noticing some changes in my behavior and this whole urge to wash my hands. And sorry, I'm hearing myself. Is it okay? Sorry. I think it was this technical. It's fine. Sorry. And yes, this sudden urge to wash my hands all the time, and especially before, you know, any activity.
So during a day, how often do you wash your hands?
Might be 30 to 40. I don't know. I do it before brushing my teeth. It's the first thing I do in the morning, so, and the last thing I do at night. I do it before and after any major activity, before eating, before I don't know, anything really, before cleaning, after cleaning, but I guess that's normal. But I don't know, sometimes I just get out of bed or whatever I'm doing and just wash it because I feel like they get icky.
And before that work accident?
Not that often, really, not often at all. I mean, I never really counted, but not many times, just before eating and I don't know, after going to the toilet, like any normal person, I guess. Normal, well, you know what I mean.
Okay, I understand. Can you tell me more about your childhood?
Sure. I have an older brother. I grew up in the capital city of where I live. I went to school. I didn't have many friends, but I didn't feel lonely. I had a dog, which I really loved. It was my only pet. And I was very much into mathematics and physics at school. I enjoyed English as well, but I enjoyed mathematics a lot more. And I don't know, is that enough?
Yeah, thank you.
Welcome.
You mentioned about that accident. Did anyone was hurt during it?
No, nobody got hurt. Everyone is safe to this day. We don't really talk much about it, but people, my colleagues didn't get affected really. I mean, we do talk about having nightmares at times, but that's all. But I didn't really notice them washing their hands as often as I do.
Okay. Did you have another usuals?
Sorry? I'm sorry, I didn't hear that.
You did another things?
Other than sometimes I arrange my items right before using them. So I would wash my hands and I would put my things in a particular order so that I don't have to, you know, do too many actions with my hands before using them. But it still has to do with washing my hands. But that is something that I do. I am a lot more aware of where I place my items and how I use them and how I touch them and what I do with my hands right after that.
Okay. And do you think it would be something that can make you change to stop this?
Well, I tried just not doing it. That was the first thing that occurred to me. But I get this sense of danger if I don't do that. If I don't do it, I just feel a sense of helplessness, and I don't really know what to do it. I get this very feeling of doom. I don't know what to do about it, so I just end up washing my hands, and it feels okay for a few moments, but then I feel a little bit, not ashamed necessarily, but I feel like, I don't know, I failed.
Okay, that you mentioned about the nightmares. How many hours of sleep do you have?
Sorry?
You mentioned about nightmares. How
Yes.
many hours of sleep do you have?
I do sleep 7 to 8 hours. I didn't notice a change in my sleeping pattern, but I do have these nightmares and I wake up very tired, and I also am quite scared to go to bed because I'm scared of having that nightmare and then waking up tired and having that, doing the whole thing. But I do sleep. I didn't notice a change in my sleeping time.
And what's your mood right now on a scale to 1 to 10?
I don't know, 7. I'm fine. I'm just a little bit nervous. That's all.
What are you thinking about other people touching your things without washing their hands properly?
I do feel very uncomfortable. I did have this discussion with my friends. I'm not really having people over anymore because of that. It's changed my dynamics with my friends because I cannot stand them touching my things when I'm at home, and there's this very difficult situation where I cannot ask them not to touch my things because we're in the same place and they're at my house, but at the same time I just feel very ashamed to ask them to wash their hands in my house. I feel like it would make them feel uncomfortable, but at the same time I have to ask them to do it, and I notice a change in their mood when I do it. So yeah.
And when you were little, your parents put you to wash your hands very often? Or...
I don't recall that, honestly. I don't really remember. I remember washing my hands after playing, yes, but I don't think that's what I don't know. But I mean, they did ask me to wash my hands before eating, after playing, after going to the toilet, just things like that.
Okay.
Do you think
Stefanie,
we can
could you
help you?
Sorry?
Do you think you need the help from us?
Well, yes, I would very much thank you for helping me if you can in any way. I hope you do. I think this habit kind of restricted my activities in a way that I'm not really getting that much pleasure out of doing things that I used to very much enjoy, like painting, for instance. I used to really enjoy painting, but now I get very anxious about staining my hands with paint, and I'm very aware of how I'm holding the brush so I don't get paint on my hands. And even if I do wash my hands, the stain, you know, it doesn't really go away, and then I just feel very aware of my hands, and I don't really know. I feel like I don't know how to use them really. So
Okay, Stephanie, I think that's all.
okay, thank you.
Thank you for your time, and we are gonna talk with each other, and maybe we would be able to find a solution for you.
That would be great. Thank you. Thank you very much.
Thank you too.
Stefanie, before going, would you tell us how you felt about the interaction with them as a feedback? How you feel about it?
So it's feedback time now. Okay.
Yeah.
Well, I think it was a good flow. I mean, I got some questions which I thought were very useful for me, and they gave me a lot of things to think about and motivate what I had to talk about. And I don't know. I mean, I felt quite all right.
Okay, so if you are a patient and they would be the doctors, would you have left the office feeling well that you've discussed with them, or?
Yes, maybe, I don't know, maybe the pauses were too long, and those made me a bit anxious because in those pauses I was always wondering whether, I don't know, they're thinking about my condition, or they're about to tell me that it's something that, I don't know, they cannot help me. So maybe a little bit of small talk in between the questions, or trying to get more information, just.
Okay. Any other feedback that you want to give?
No, I'm fine. It was great.
Right.
Thanks.
Okay, thank you very much. Thanks a lot.
Thank you.
Right, yeah. So thank you. It was actually very, very good, to be honest. Should we Ioana, do you mind stopping the spotlight on Stefanie, please?
Oh, I already did that.
All right.
I
Okay.
can see you now.
Oh, great. Yeah, so I think it was really good. What do you think now? You did the first part. You should arrive at a diagnosis. What do you think is the diagnosis? I wouldn't ask you, but you probably know it. That's why I'm asking you. Yeah, that's correct. That's the diagnosis. So I think it was really good. To be honest, I liked some of the questions, like how often do you wash your hands? That was a really good question. And you also asked Anna, I think, about if they have any other things apart from any other compulsions apart from washing their hands. That was again a very good question. I wouldn't have. I think depending on the interview, if it was again a real life interview, as the scenario suggested, I would have gone into childhood, but not as fast. And probably if you are like in a thinking about the task, you probably wouldn't need to do that. Not that it was a bad thing. I'm not saying that. I would go into childhood if it was a real life scenario. But otherwise, I mean, thinking that the task, it wasn't a thing that you necessarily had to do. Right. I think when you ask her about, do you think you need help? Probably that wasn't necessary. Probably that wasn't the necessary question, just because reading the scenario, she was referred from the GP to you and she came to see you. So probably she thinks that she needs help, otherwise she won't be here. There was fine from this scenario. I'm just saying it because if you ask some of the patients about this, they might get angry and say something. Of course I need it. Duh. That's why I'm here. It happened to me, you know. So that's why I'm saying I did ask that in the past. And they weren't very happy, which is understandable. You know, when I thought about it, I thought, well, probably I would get angry if I would be asked that. Otherwise, it was good. Now we can all go back and see each other. In terms of OCD, I think we need to bear in mind 3 things. So OCD means obsessive compulsive disorder. So you need to have obsessions and compulsions. Obsessions are thoughts, and compulsions are the result of the thoughts. So basically, hand washing was a compulsion, not the obsessive thought. The obsessive thought could be something like, if I don't wash my hands, I will die, or I don't know, someone will die. Or if I don't do that repetitively, someone will die. And then the actual compulsion is what they do, the action. These are the things to bear in mind with obsessive compulsive disorder. And probably at the same time, you need to explore if these obsessions are their own or they are more psychotic in nature. So asking, are these obsessive thoughts yours, or is someone else putting them into your mind? Because people who have psychosis might have these obsessive thoughts, but they are related to psychosis. They think that someone is putting these thoughts into their mind or making them do this. So I think that was it. I think exploring the mood was a good thing because you need to see if they are depressed or not. It was, I think, at the end, our actor Stephanie offered some of the information you might have asked directly, and that was, what's the impact on your day-to-day life? That's an important question, because if the compulsion has no impact on the social life, then you might not necessarily have a formal diagnosis of OCD. It has to have some impact on your social life to be formally diagnosed as OCD. Otherwise, you might have OCD traits, but if you see someone who has OCD traits, and then they will say, well, I don't mind, they don't impact my life, I don't care about them, then that's not OCD. People with OCD, they don't like what they do. They don't like that they wash their hands, but they can't stop because they think they will die. If they like what they do, then that's probably not OCD. Yeah, I'll finish with my rant about OCD because then we'll finish at night. Do you have any questions? Anyone? Right. Should we move to team number 2 and scenario number 3? I think team number 2 is Isabella and Simona.
Yes.
I hope I got that right.
Yes, yes.
Right. Let me share my screen. So this is scenario number 3. So Mr. Lionel is an 80-year-old male who has been admitted to the psychiatric ward for an acute change in his mental state. Prior to this, he has been well and does not have any chronic medical conditions. He does not have any underlying pre-existing psychiatric disorders, so he was fine before this admission. The team has evaluated his condition and has done some baseline blood investigations and brain scan. All the blood investigations were within normal limits. The radiological investigations, which was a CT scan of his brain, did reveal a suspicious lesion. The neurologist has been called in for a further evaluation, and they feel that the lesion is most likely that of a brain tumor. It doesn't matter what brain tumor, just take it as a brain tumor. His son, who is his main caregiver, and his son is called Jim Lionel, is currently here and hopes to find out more about his condition. So your task is to speak to his son and explain more about his current condition. You don't need to go into technicalities about the brain tumor. So it's about communication and breaking bad news. So communication with caregivers and breaking bad news. You don't need to know details about the brain tumor. And please try to address all his concerns and his expectations. Great. Do you need time to talk between yourselves or?
Yes,
not?
Yes.
a bit.
Right. Okay. I'll put you in a breakout room. Right. Do you have any questions about this scenario or the previous one? Or the others in the meanwhile?
I have 2 other questions. You said before that patients with the OCD don't like their habits or washing their hands or other compulsive. You said that it's another kind of patient that likes that that habit. What disorder is that? And how we can?
Sorry?
What disorder is that when a patient like their habits, their compulsive habits?
Well, then it's probably not. It's not OCD. I don't know what it is. You need to explore it more. It might be more of a tic than OCD. It depends of what's going on. But the patient with OCD, he won't like. He is aware that he does that, so he has all the insight in the world. He'll be like, I know what I'm doing. I don't like that I'm doing it, but I can't stop myself. So there is a high level of distress when you try to stop them from doing it. Hence, the therapy that works best is exposure therapy. You try to expose them little by little to that stimulus that they don't like, and actually prove them that nothing wrong happens. Because the problem with OCD is that all these compulsions are done to avoid something bad, something very, very bad, like my family will die, I will catch COVID, I will whatever. It's a bit different to health anxieties. Is an anxiety. OCD is an anxiety disorder, part of the anxiety disorders. But with health anxiety, you won't do necessarily compulsive things, right? It might be health anxiety, you know, when you ask about what can be health anxiety. So if someone is anxious that he will get COVID, he will wash his hands and he would be happy after he washed his hands because that's how he or she avoided COVID, but that's health anxiety, it's not OCD.
Thank you.
You're welcome. I hope this answers your questions without confusing you a lot. Do you have any other questions?
Yes, and in OCD, some we can observe some, I don't know, brain changes or something like that on a scan of the brain. Or maybe
Well,
I can
there are
triggers that OCD, how the person, what is the pathological behind
right.
that OCD?
Okay. Yeah. It's usually a traumatic event that happened in their life, and that triggers it. As in a way, all anxiety disorders. At times, it's quite hard to pinpoint what triggered it. And again, this is probably not the purpose of any OCD therapy to find what triggered it, but rather to treat it. Interestingly enough, most of the newer psychotherapies don't necessarily focus on what triggered the event, but rather what's the solution for it. But it can be a lot of things. One is the need to have control over something. You lack control in all areas of your life, and that's something that you see in adolescents that have very controlling families. They would lack control in other areas of their life, and they would start to find something that they have control about, and that can be an eating disorder, that can be OCD, that can be a lot of things. But it comes back to the same thing of control.
Thank you.
You're welcome. Right, let's start with the second scenario, third scenario. Okay, so Jim Lionel, if you could come on screen.
Hello.
Hello.
Hello, can you hear us?
Well, yeah.
Okay, I'm Simona. I'm one of the doctors from the psychiatric ward. Isabella is my colleague. Can you ask you a few questions about your father?
Please go ahead.
Okay, how should we call you in the first place?
I'm Jim.
Okay, so I've heard that you are here in concerns of your father, and we should talk about that.
Right.
Okay, so what did you notice differently about him? What were the symptoms that scared you?
Okay, so everything felt normal.
Okay.
4 months ago, when he kept having he didn't know who I was. He was like he wasn't aware of the place.
Can you say that again, because it interrupted it at some point? So 4 months ago, okay.
So everything was, I said, was fine until 4 months
Okay.
ago, and then I noticed that he had confusive state of mind. He didn't know where he was. He didn't know who I was, and he kept having compulsive patterns. He kept asking for apples. He kept asking for coffee, even though he already had coffee. He kept going to the bathroom for like 5 or 6 times in 1 hour. And then, that was the time where I noticed that something might be up with him. So I thought the best decision was to bring him to you guys and see what's up with him. And that's
okay, so that was happening all day long, or just one thing here and there?
Right, the confused, yeah, all day long.
All day long, okay.
I mean, he had like episodes of it, yeah. But
there were times when he was fine, and...
What do you mean by fine?
Normal, as you knew him without the confusive state of mind.
Since he did that, nothing felt like normal anymore.
Okay, Isabella?
Did he also feel like he was talking to someone, like hearing voices, or?
No, none of that stuff. No.
Okay, and another obsessive thoughts he had, or compulsions? Another obsessive thoughts he had, or did he do anything unusual?
Unusual, yeah. I thought that I told to you guys that before. He defined unusual. I mean, he was like asking for apples, asking for coffee, going to the bathroom, didn't know where he was. That kind of stuff, which made me feel very worried somehow.
And if you explained to him that he already had apples or that he already got...
He wouldn't understand it. That's what he wasn't aware of his...
He wasn't aware, so even with your help, it wasn't any better.
But can we please move on? I mean, I would like to know what state is he in right now, because I'm pretty worried.
We got the neurological CT scan, the results.
Okay.
And your father has a brain tumor. We're sorry to give you this news, but he has this tumor, and this should have been given him the psychiatric symptoms. He's not a psychiatric patient, but by himself, but he has a neurological disease right now.
Okay, move on.
We know it's hard, but you...
Okay, so what now? Can I take him home?
He should receive treatment, because even if the problem is neurological, we should also treat the symptoms.
Even at home, there's no problem. Just give me the prescription. I'll take care of it.
I think that he should remain here.
I think I'm pretty capable of doing that, you know? So I'd like to take him home. Just give me the papers. I'll sign them, and then we'll take him home.
So you wouldn't consider him being admitted?
I don't think so. I mean, so if you tell me more about the treatment itself.
So first we should treat the neurological problem so that the psychiatric symptoms would alleviate and would get better in time. And that's why he should receive treatment.
Me taking him home right now?
It's better if not. It would be better for him to receive treatment and to that problem to be dealt with.
Okay, so what about the bill itself? What about the prescription drugs, whatever?
We will prescribe that, but we should also talk to the neurology department, and and I will talk to my colleague, and then we'll decide which treatment.
Will he leave? I mean, I want you to be honest as you can get right now with me, and tell me if he's gonna leave or not.
We are doing the best we can for him to be better.
But there's a but, right?
It's more about the prognosis that.
Okay, what about it? Just be honest.
We don't know yet. We don't know yet.
You don't know yet.
Yes, the better you need a neurology specialist to assess this problem.
We are dealing with the psychiatric symptoms. We are psychiatrists, and that's why we need to talk with the neurology department. So is it okay if I talk with my colleague and then we talk with the neurology department and then we'll all explain to you?
Of course, yeah.
Okay. So thank you. and we will get back to you with all the information.
Okay.
Thank you.
Thank you.
Right. Okay. Thank you. Jim, could you give your feedback about this?
Well, it felt all right, I guess. It felt all right. Of course, considering the way I felt, and so my mood, to say so, it wasn't. I needed like more informations, but I figured that none of your the script doesn't offer you that much information, say so. But what I would say, I would pinpoint to have a better adjustment or a better improvement would be talking and taking in consideration the way that I felt, the way the patient felt, and phrases like "it's okay for me to go on," considering the moods that you're in. But overall, I felt it felt all right, felt fine. And considering the fact that I wanted to take him home somehow, giving me the rational reasons for him to stay in the hospital, as it's better for his health, I guess. Doesn't know if I make sense what I'm saying, but
yes, it does.
Okay. That's about it. But it felt good. I felt like I had some real feedback, and the way that you reacted to my behavior, which was unexpected, I think.
Yes, it was.
Was good, I think. Yeah. Right. That's all. I think. Yeah.
Thank you.
Okay. Thank you very much. Thanks. All right. I think that was a hard one.
It was and scary because the whole.
I know. I think. I know. I think in a way that was the idea to have a more difficult relative, as this would be a thing that you would be doing as a resident doctor or a junior doctor. You will be breaking bad news. Often of investigations that weren't done by you, and often with you not knowing a lot of information about that particular condition. That's a very realistic scenario, to be honest. And yes, you will encounter some very nice relatives, but you also encounter some relatives that are more distressed. Not that they are rude or anything, but they are obviously distressed about what's going on. And they need to receive some reassurance. But given how difficult you are, and how difficult it was, and that you aren't experienced at all, I think it was really good, really good.
Thank you.
I really liked the introduction. And another thing that I liked quite a lot, I know that's something that we don't tend to say in Romania, and that's quite bad, is I'll talk to someone else. When you said I'll talk to my neurology colleagues, that was really good. That's what is expected from you to say. So in interviews in the UK, when you come as a junior doctor, that's the first thing that people would expect you to say. So if you're given a scenario where it's pretty obvious that you don't know the disease, if you start inventing things, you'll fail that interview for sure. So the best thing is to say, I'm not pretty sure about this, but I'll talk with whatever, with my colleagues, whatever, and I'll come back to you with more information later. I'm sorry that I can't help you now. But it was really good that you said you'll talk to the neurology department. It was very good, Isabel. I think you did say you were the one who broke actually the bad news.
Yeah.
You were the bearer of bad news. And I think
Well, I was taught to how to give bad news, so I
I think the only thing
in university we're not being taught how to do that, and it's overwhelming to.
I think it's
the
overwhelming.
psychology classes are very theoretical, but nothing practical in order to how to talk to patients and so.
Yeah, I think overall it was good. I was a bit afraid in the beginning because the beginning of it sounded a bit too direct and too blunt, but then you said, "I'm sorry to tell you that," which was really good. So probably if you pack it a bit more nicely, even though it might sound that you beat the bush around, things, but then if you pack it more like, look, we did bloods which are normal. We also did a CT brain scan, which unfortunately shows an abnormality, which most likely is a tumor. I'm very sorry to tell you this now, and then give them a bit more time, and you can say something like, "I'm here for you if you want to ask me any questions related to it." That would be helpful. So I think that's probably about delivering bad news. It's difficult regardless of who does it and whatever experience they have. It's always a difficult thing. So probably that's what I would have done differently. I would have probably packed the initial bit different. And then obviously it would have been, as Jim said, would have been more reassuring if you'd have been able to give him more information, but obviously you didn't have that information. I think the only thing I would say in addition to this is when he mentioned taking him out of the hospital, you probably should have been a bit more clear, saying something like, of course, if you and him decide about it, that's an option for you to have. But let's think about all the options first and then discuss about this, rather than because it seemed a bit like you were forcing him to remain in hospital, which might end up bad in a different health system than the Romanian one. So it'd be more like, of course, you can take him back home. That's one of the options you obviously have. But there might be other options. So let's explore all the other options as well, and then you can take whatever decision you want to take. That would have been probably a nicer package. But that's definitely not a negative feedback for you at all. Do you have any questions?
I don't think so, but it was a nice experience overall for our future careers.
Right. Okay. I'm happy to hear that.
Thank you.
Right. Should we move to the next scenario? And while we are waiting for the breakout room, you can ask me any questions you might have following this scenario. So I'll share my screen again. So we'll move to the fourth scenario. I think that's team 3 with Andrea and Steffi. So scenario number 4, we have Mr. Thomas Smith, who's a 35-year-old man who has just been admitted to the orthopedic ward after sustaining a fracture of his hip when he slipped and fell whilst bathing. He had his hip operation 2 days ago and is currently being nursed in the surgery high dependency unit. Has been complaining to the nurses that he has been seeing Spanish guerrillas around. He has been aggressive and agitated most of the time, as he believes that these Spanish guerrillas might hurt him. And your task is to assess him for his current symptoms, perform a risk assessment, including alcohol and substance misuse, risk to self and others, and if you can, think of a diagnosis, that's probably secondary if you can think of it. If not, focus on the current symptoms and what's the risk to himself and others. Do you have any questions?
What do you mean by Spanish guerrillas ride animals? Or...
No, not gorillas, but guerrillas. Like armed people. Yeah, armed people. I haven't invented these scenarios. These scenarios are actually, I haven't told you, but I'll tell you, these scenarios are actually scenarios that are played for the specialty examination for psychiatry in the UK. Right, so if you don't have any questions, I'll move you, Steffi and Andrea, into a breakout room.
I would like to ask you, but it's more like my curiosity.
Go ahead.
I heard that if you're trying to kill yourself, the police will give you a fine or something like that. It's true?
In the UK, not. I don't know about Romania. As I said, I have no idea. In the UK, no. If you try to kill yourself, then you'll probably be what's called sectioned, which basically means involuntary admission to a mental health hospital in the UK. But you won't get fined.
Yeah,
and
it seems like no sense if you want to kill yourself to give you a fine. I mean,
yeah, no.
Yeah.
Right, so we shall invite Mr. Thomas Smith.
Okay. Hi, my name is Irina, and this is my colleague Stefania, and we are from the psychiatric department.
Look, sorry, there's no point for us having a chat right now. We need they're coming for me. We need to escape this war zone right now.
Okay, you need to calm down. Who's coming?
No, the Spanish guerrillas, they're at the door. I can hear them. They're very, very, very loud.
and why they are coming?
I don't know. They're coming to get me. Wait, who are you?
I'm Irina. I'm here to help you.
Who are you?
I help you to get away from them.
What? Can I trust you?
Yes, you can trust me. I'm here to help you. That's why I'm coming here.
Are you a doctor?
Yes. Coming to fight with them.
Can I trust you? Okay.
Yes.
Okay.
So what is happening? What are they trying to do to you?
They're very loud. They're pounding. I can hear them at my door. They're pounding and screaming and shouting. I can't really understand what.
How long have they been following you? Have they been trying to come for you?
I don't know. Since this morning, since this morning they've tried to come here, and they're very, very, very loud.
And what do you think we should do to get out of their way? Do you think?
I don't know. I tried to block my door with some furniture. But they're very, very loud. I can hear them. They're screaming all the time.
They cannot reach you. You are safe here. We are safe with us. They cannot reach you, but we can. We need to find a way to escape from them. So can you tell us? Do you have any idea how to escape?
What
Hello.
is happening to you?
There's one. There's one at my window.
They cannot reach you. They can enter there. They
Take
cannot.
Take your focus off them and try to talk to us about it. Maybe they will stop.
I don't know. I tried to protect myself.
How did you try to protect yourself besides the furniture?
I tried to throw a chair at them, and they would still come, but they're very loud. They are very, 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 very loud. I can
look back at us and try focusing on us. What can we do to help you?
I don't know.
Is anybody else out there beside the Spanish guerrillas?
No. It's just me. It's just me. It's just myself.
Has anybody else seen them?
What?
Has anybody else seen the guerrillas that are following you?
I don't know. I think they're trying to trick me. They're all against me. I don't know. That's why I'm asking if I can trust you, because I can see them. Yes. and I can see them, but I'm all alone here. Oh my God,
no,
they're very loud.
No, you're not alone. You're with us. You can trust us. You're not alone.
Okay.
You're not alone. You need to focus on us and to talk to us. And I think that they will disappear because you are not focusing your attention to them, and they will go.
I'm trying, but I can hear them sometimes. Okay.
Yes, you can hear sometimes. They will disappear. Trust us. They will disappear.
I hope if you can help me, please.
Have you heard them before? Is this the first time they are trying to do this?
Yeah. This is the first time since this morning. It didn't happen before. It happened just today, just this morning. I kept hearing them. Sometimes I saw some of them. They're very, very, very tall, and they're very, very loud, and they're scary eyes.
Do you think they can do something to hurt you? Do you think they want to?
I don't know. I think I'm trying to protect myself. They tried to come at me, but I dodged them. I tried to protect myself. They haven't hurt me so far, but my hip is in pain.
Marcel Pavel a amenințat că vă dă în judecată pentru aceste afirmații.
What?
Voastră nu v-ați oprit din demersul public de a presupus.
There's nothing going on. Everything is fine.
There's nothing going on. What about the operation? Can you tell us about operation? Are you afraid? Were you afraid about the operation? The surgery?
I don't know. It just hurts me a little bit.
But what happened? Why did you need the surgery? What happened to you? You fell in the bathroom, but how did that happen?
I fell in the bathroom. Yeah.
You don't remember exactly what happened? Did you lose consciousness?
They were trying to get me. They were trying to get me. Yeah. I think it was them. It's most probably.
Okay,
you
so
tried to fight with them, and that's why you tried to fight with them, and that's the reason why you fell in the bathroom.
I think so. I don't have another explanation. Yeah, yeah, I think so.
Can you hear them?
All the time. I can hear them almost all the time. They're shouting.
Before hurting your hip, have you heard them?
I don't think so. No. I don't think so. No.
Okay. You can remember the first time when you started to hear them?
When I woke up this morning, yeah, I woke up and I started to hear them, and the screams began to be louder and louder and louder.
What are they screaming?
I don't know. They're pretty pissed off. They want I don't know, freedom. I think they look like they're all masked and covered. I can't. They're very tall and they have very scary eyes.
They're saying something exactly. They're saying something exactly.
I know. I can make it. I don't speak Spanish. I can't make it. I don't understand. They're just coming. But I know they're coming for me because they're shouting at the door. And
okay, come back. Try remembering the bathroom incident. And before that incident, did you feel something weird? Did you feel that something around you was not okay? That someone was doing something to you?
No, just no. Before, no.
Did you feel safe before the incident?
Well, I felt quite safe, but I live, I live alone, and sometimes I start thinking about things, but I felt generally quite safe. I didn't feel really in danger.
And when you start feeling alone, what do you do? Do you find something to do? Do you, I don't know, smoke, drink a beer, or do something like this?
No, I don't smoke. I don't smoke, but I drink. I do drink.
What do you do? What's your favorite drink?
What do I usually drink whiskey. Yeah, I usually drink whiskey.
Okay. What does usually mean? Do you drink a glass a day, more glasses a day?
You know, I drink maybe a glass or two, or I don't know, but I do spend quite a lot of money on alcohol if I think about it right now. Yeah, but not so much.
Okay, that's fine.
Alcohol makes you feel better when you drink. You feel safe when you drink.
I feel a little bit better. I tend to forget about what I have to do, and I feel more relaxed. Yeah, most of the time. Yeah.
And lately, did you feel the need to do that more often?
I don't know. If maybe I drank a little bit more than I usually do.
Okay. And can a day pass without you drinking, or do you need to do that every day when you feel unsafe?
Oh, I had some breaks from time to time, but you know, just one day passing. But I haven't had a long break. Just you know, a day, sometimes maybe, no, yeah, a day. Yeah.
That's
Okay,
fine.
and when was the last time that you drink? You can be honest with us.
Well, I think it's been a few days. A few days, yeah. It's 3 or 4 days. Maybe.
Did you drink in the night that you felt in the bathroom? You remember that?
Yeah. I think I had a few drinks. Yeah, I think I had. Yeah.
And now that a few days passed, do you feel the need to drink? Does it bother you that you didn't drink these days? Would you have preferred to drink?
I don't know. If I think about it, I think I would feel a bit more relaxed if I had a drink right now. But
okay.
It's so loud. It's just very, very, very loud. I can.
We'll try to find a solution to make them stop and help you. And
we promise you that we are going to make them disappear and to make you to feel better. You can trust us. Don't forget that. And you can call us whenever you want to talk with someone, and whenever you feel unsafe, you can call us.
Okay. If I can.
We will talk with one to each other and with other doctors, and we will came back to you to make them disappear. We promise that we will make them disappear from your life.
Yeah. Okay.
Thank you for talking to us and being honest. And we'll come back with a solution for you.
Oh, thank you.
Thank you, Thomas. Would you give us your feedback before going off camera?
Yeah, sure. I really felt safe. I don't know. I felt quite good. I was scared a little bit in the beginning. I don't know. There were some sounds, some television in the middle of the interview.
Yeah.
But it wasn't really that distracting. I think it was quite helpful for me to continue with being scared. But it actually went on a really peaceful path, and I felt quite safe. I don't know.
Okay, thank you.
Thank you.
Thanks a lot. Yeah. So now my question is, what do you think is the diagnosis?
Oh, it's an alcohol disruption sevrage or something. I don't know.
Yes, I think that is related to the alcohol addiction that he has.
Yeah, the stopping of the alcohol consumption.
Yeah, so this was a scenario related to delirium tremens, obviously due to alcohol. But you should always, when you see, I chose it specifically because you have a lot of alcohol addicts in Romania, but not only. And also you'll see patients with delirium, not alcohol related, but related to infections in hospitals. So that's something that you would see regardless of your specialty. So whenever you see someone in a hospital setting that has vivid visual hallucinations, as a rule of thumb, visual hallucinations are very rarely psychiatric in nature. Most of the times are related to some form of neurological disorder. Most of the times you encounter them in different forms of delirium. That's probably the first thing you should have in your mind when you're seeing someone who has visual hallucinations, especially if they are in a hospital, in acute hospital, for whatever reason. And obviously, if they are alcoholics, that's another thing. I think this scenario was somehow, was difficult because he wasn't mentioning specifically alcohol usage in it, but it was hinting at he felt in the bathroom, and then I think the original one was a bit harder because the patient was older, so then it was a bit more difficult to think that he was actually an alcoholic. But they try change it to a younger chap, and then you obviously think, well, why would a young chap fell in his bathroom? So yeah, so coming back to that, I think it was really good, especially because it was really difficult with him being so distracted by the hallucinations. The only thing I would say in the beginning, Andrea, you said something along the lines, we will come to fight them with you. I think that was my understanding, kind of saying that you'll be helping him to fight the guerrillas. Tell me if I'm wrong. So what I would say is never ever encourage a delusion or a hallucination. Don't necessarily antagonize it. So when a patient would have a hallucination or a delusion, they really believe that, they really see that. It's as if I would tell you now that you are a man and not a woman, although you know that you are a woman. That's reality for them. So don't antagonize them, but you could say something like, I understood what you wanted to say. It was really good because you made him feel safe, and that was the purpose of it. But the way to do it would probably be something along the lines of, I can assure you, Thomas, there are no guerrillas around. You are now in a hospital setting. I am a doctor, and there aren't any guerrillas around. So that's probably a better way to do it. I really like that Steffi continued to ask him questions, although they seemed a bit blunt at times, but that's what you should do because he will repeat that. Obviously, he's really distracted about it, but you need to kind of focus on your information gathering. So at times you need to be a bit blunt with this kind of patient to kind of see what's going on, because they would go on and on about this because they are distressed about it, and then you might try to be empathetic with them, but you won't succeed in gathering any information. So that was really good. Especially with delirium, any kind of delirium, try to assess if they are oriented to time, place, and person. So kind of try to ask them, do you know where you are now? Do you know what day is it? Or do you know what's the time now? It's important to assess if they are oriented to time, place, and person, because that's another give of a delirium. They're not. What else? Yeah, probably that's far from being a negative feedback in terms of his hallucinations. I think you asked quite a lot of questions. not necessarily very structured, but it was good. It's probably when you encounter such a patient that has very vivid hallucinations, it's worth exploring them all, like going through full visual hallucinations. And then I think you did that with hearing voices, trying to explore a bit more if the voices are coming from inside of the head or outside of the head. And that's a good information for the next team, by the way. If the voices come out of the head, those are called true hallucinations, are kind of psychotic hallucinations. If they come inside of the head, are most likely intrusive thoughts than real hallucinations as such. So this kind of, and then see if those voices are commanding in nature, so if they're telling them to do something, if they are trying to make them kill themselves or kill others, it's really important to relate it to risks. And then maybe try to explore, very rarely they might have like, tactile hallucinations, olfactory hallucinations, so maybe kind of quickly go through them, asking something like, have you noticed any change in your sense of smell, or have you had any other unusual experiences, like feeling that something is crawling underneath your skin? Some patients have, especially the ones with delirium tremens, have very vivid hallucinations in all the senses. I think that's pretty much all. You did a very good alcohol screening. That was good. That's probably a thing that you need to know how to do everywhere in the world, in Romania as well, because you'll encounter a lot of alcohol addicts. And I think you haven't touched it, and it's not so frequent in Romania, but it's very frequent outside. Ask about drug addiction as well, because some of this vivid visual hallucinations are actually triggered by synthetic cannabinoids, the legal highs or spices, or however you want to call them. And you have very vivid and spectacular hallucinations with if they are induced by drugs. So that's worth asking them, even if they don't seem to be drug addicts. Do you have any questions? Because I've been ranting a lot.
Yes, I have one question again. We can differentiate about the inside voices and the outside voices. You said that the patient can hear voices that are outside and inside.
Yeah, you just ask them. So if you will ask something like, do you hear any voices? And they would say, yes, I hear 3 voices. And then you will ask them something like, do you think that they're coming inside of your head, or you can hear them as you hear me now? Okay. And then they would usually be able to tell you how they are. And then you can ask, can you communicate with them or not? That's another thing. You just ask them directly. They would usually know how they are.
Yes, thank you.
You're welcome. Steffi, any questions?
I'm fine. It was really a really nice experience, but quite distractful the way he was looking around. I couldn't get to him.
It's really distracting. So I think the takeaway from this is you need to keep focused on what you need to ask, because otherwise it's very easy to get distracted. And I'm happy that you've been blunt at times and get through that and ask him some questions that had no connection to what he was saying, but you wanted to get that information. Right, so then let's move to the last one. This is team number 4. So this would be Emma and I think Ioana, if we don't have the other participants.
Or if somebody else wants to do another scenario
Oh,
We
yes,
can create
someone else
quizzes.
wants to do. Yes, of course. That's a good idea. Do we have another volunteer to team up with Emma?
I can try again if no one wants.
Okay. So I'll put you both in a breakout room. Well, actually not. Sorry. I actually need to show you what's the scenario.
Yes.
Just a small detail. Right. So this is the last scenario. We have Samantha, who's a 25-year-old female. She has been admitted to the emergency services following her attempt to overdose on medication. This is her third visit to the emergency services within the past month. The medical team is concerned about her recurrent overdoses and have requested the on-call psychiatrist to speak to her to determine whether she has any mental health issues. You are the on-call core trainee 3, and your consultant has requested that you assess the patient first. And your task would be to speak to Samantha and obtain as complete as possible, bearing in mind the time limitation, history from her. Do you have any questions before going to the breakout room?
No.
Right. Okay. Right. Are there any questions from the past scenario, or any other questions that you might have while we are waiting for them to prepare?
I would like to ask you if schizophrenia is treatable or not.
Yes, the answer is yes. Very treatable, actually. One of the easiest to treat conditions, psychiatric conditions, actually. Obviously, you have, as in any other illness, you would have patients who fail to respond to medication, but that's a small percentage. And yes, you will have, it's a chronic condition, so you will be like the same as treating hypertension. So you won't cure it, but you can keep the patient stable and functional. And completely normal, if that's the question, if there is a normal.
Yeah, thank you.
They will be on an antipsychotic for the rest of their lives, and obviously if they stop it, there is a high chance of a relapse in someone with schizophrenia, and that's what actually happens usually. They will have a first episode that will be treated, they will return to a completely normal life, and then at some point they would stop their antipsychotics because they're well and they think they don't need them, and then the history repeats itself. Or you have unfortunate cases of patients that have paranoid schizophrenia and they would never gain complete insight about their condition. So even when they are well, they won't agree that they were unwell earlier. So obviously that leads to them stopping medication and a relapse. But otherwise it's treatable.
Okay. Hi, my name is Irina, and this is my colleague Emma, and we are doctors in the psychiatry department, and we are here to talk to you and to be a partner to you, to tell us what happened. Do you know why you're at the hospital?
Yeah.
And why is that? Can you tell us? We want to know it from you.
Because of my overdose.
Okay, and can you talk to us about that? Why is that overdose?
I don't know.
you had other 3 this month. Why? Do you want to hurt yourself?
I guess, yeah.
Or is just a passion of you to take drugs?
No.
How do you feel right now?
Not very good.
Can you tell us why?
Because I just ruined it again.
Sorry, can you repeat? You just...
I ruined it.
What did you ruin?
I'm alone again.
Why are you alone again? What means alone?
Because he broke up with me.
Okay, he was your boyfriend, right?
Yeah.
Why? You have a fight? You have some discussions?
Yeah.
About what?
I don't know. He would just get in fights, but for no reason.
When did he broke up with you?
A month ago.
So when you started overdose, right?
Mm-hmm.
You suffer? You suffer?
What do you think?
I think I want to tell me. I want to hear it from you. I cannot suppose anything. I want to listen to you.
Yeah.
Okay.
Some people might think of suicide. Was that your intention?
Yes, and why, what was so special to him? Your life is more important than him.
Yeah, right. That's what everybody says.
Because it's true. Do you have a child or something?
No.
Do you have family?
I have family, yeah.
Why?
Do you live alone? Sorry, do you live alone?
Yes, I do.
And how often do you visit your friends, your family?
On holidays when I have to.
You have to, you don't get along with your family?
No.
Tell us about.
What?
Why is that? Why don't you get along with your family?
Because they're stupid. I don't know. I've never gotten along with them. Because they were never there for me, so.
Do you feel abandoned by them?
Yeah.
Okay. And do you have any best friend or something like that?
I have.
Okay, and you don't feel like you can talk to them and tell what you feel?
I talk to them, but they never understand what I'm saying, and they always say I'm overreacting, so no.
Okay. And can you tell us what do you feel when you overdose? You feel freedom, you feel safe, what do you feel?
I feel freedom, I guess. The numbness helps, but it seems like I can't even do that right, because I can never go all the way through.
Do you have a good thing in your life, a good person, anything good in your life? Can you tell one good thing that happens to you that you have in your life?
I had him, but I don't have him anymore.
I'm sorry, I think that can you repeat it? Was the internet?
I'm sorry. I said I had him, and he used to be the good thing in my life, but now I guess no, there's nothing.
How? Sorry, if you saw him when you walk out of the hospital, would you want to hurt him because what he did to you?
Yeah, but I also want him back.
How long have you been dating?
6 weeks. But he really was the one.
Why he was the one? What was so special to him? How he made you feel?
He made me feel loved. He made me feel like there was someone there, but I don't really want to talk about it anymore.
Okay, we will not talk about him anymore. We will talk about you. You are more important, right? So,
can you tell us more about your childhood?
Not really too much to tell about. It was pretty lonely, I think, and I didn't have nicest father, but yeah.
Is it possible that your fear of abandonment is because your father?
Probably.
Maybe that's why you are so attached to this guy?
I guess.
can you tell us what your dad did that feel you to feel so unsafe?
He got angry really often, and I guess he would, I don't know, he would sometimes hit us, and yeah.
Are you afraid of men because of him?
I'm not afraid, no.
What do you feel about men then, except this guy?
Well, it depends. They can be really dicks, but other than that, I don't know. It depends.
Depends? What means depends? Depends about what?
Depends on the men. I mean, I like some, I don't like some.
Okay, I understand. Do you feel that you need help with this problem of you, with this overdose? Do you want us to help you?
No.
Why? Why is that? We can help you.
I mean, I need to feel like someone really understands me and they're there for me. I do want that, but
we are here now to help you. We are here now to talk to you. We are here now to support you.
Well, how can you help?
Sorry?
How can you help me?
We can talk often. We can find out what is the problem that is causing you overdose and to try to eliminate it.
I'm sorry, did you try to overdose in the past before this month?
Yeah.
Can you tell us when?
2 weeks ago.
No, I mean in the past, not this month.
Well, this month it already happened 3 times. 2 weeks ago was the last time, and I don't know, it happened now 3 times after he broke up with me. It happened before. It happens every time. I just can't, my chest is on fire and I just can't stand the pain anymore. And that's almost the only solution.
Do you feel good when you drug yourself? Do you feel that the pain disappears?
Yeah.
What drugs do you use?
Excuse me, I didn't hear you.
What do you use when you drug?
Well, it depends what I have on hand. I've actually started researching it because I don't know why I can't get it right, but it's usually sleeping pills.
Okay.
And if you were to leave the hospital, you will try this again?
Probably, yeah.
Do you agree to admit in the hospital and to try to talk to us and to try to make this better? Are you agree with that?
You don't get me.
Yes, we are here for you. We want to make you feel better, and maybe this will help. I'm sure that this will help.
Do you think maybe you didn't succeed because you really didn't want to in like yourself? Don't you think this is the reason you didn't succeed all those times?
The reason why? Because I didn't hear.
The reason why you don't succeed to overdose is because you in yourself you really don't want to do this.
I don't know, because yeah, sometimes I am relieved after that it didn't work, but I think it would be a lot more easier that way.
Don't you think we could find another strategy to cope with this?
I've tried all the strategies. I've tried cutting. I've tried drinking.
Not harm
everything,
yourself.
and
without harming yourself.
No.
We can try other therapies that can help you without harming yourself and without put you in risk, in danger. But you have to agree to talk to us and to let us to be next to you, to let us be your friends. You said that you are relieved that sometimes you don't succeed. So let us be your friends and to help you, to be your friends that you miss. What about that?
Maybe.
Well, then I think that me and Emma will discuss and we'll come back to you to help you, to offer you a solution, and we can try together. We will be next to you and we can try together to feel you more safe, more to feel you safe, you again, yourself again. That's right?
Yeah.
Okay.
Thank you
for talking to us.
Thank you.
Thank you, Samantha. So what's your feedback on this? How did you feel?
It was really hard this time because they went really strong in me at first. I mean, it was really tough because they kept emphasizing on the overdosing and on the pills and on the stuff, and I didn't really feel the emotional support. I felt a bit scolded on. So I tried to regain the trust, but it started very low. Or at least that's how I felt. I don't know.
Mm-hmm. Okay. Anything else?
That's it. That's it.
Right. Thank you.
Thank you.
Right. So I think you've just this is the most frequent scenario I'm seeing during my own calls, and what you've seen is a patient that presents with, make a guess. You probably don't know, but make a guess. Emma, don't disappear off camera. Don't hide away.
I'm sorry, what did you say?
What do you think? What do you think is the what diagnosis can this be?
Depression with psychotic.
Probably not. It's similar to the first one. I don't know if you've seen the first one that I did. That was the depression.
Yeah, I've seen it, but I don't know.
Right.
I don't have any idea. It's
Right.
she was a little bit complicated.
Okay, so I think what you've seen now, it's called in the British literature, well, kind of European one, emotionally unstable personality disorder. In the American literature, probably you've heard about it more, borderline personality disorder. So these are, people argue if these are actually mental health disorders or an extreme spectrum of a personality. Basically, these are people who can't cope that well with frustration. They have a lot of relationships, very short relationships. They would change partners quite often. They would self-harm quite often as a way to relieve and deal with their frustration and anxiety. I think you actually, Emma, you had a very good question. What do you feel when you overdose? That was a very good question, because they would use overdosing and self-harming as a way to relieve frustration. Now, if you'd ask me, are they treatable? I had this question about schizophrenia. The answer with this is probably not, just because it's more of a personality issue rather than a full psychiatric issue, a full illness. So it's kind of more ingrained in what they are. Again, I think I've heard questions about childhood, which is really good. You'd see usually these people who present with emotionally unstable personality disorder had a very difficult upbringing with trauma, sexual abuse, physical abuse. Very often you see that. You most likely see it in females, very, very rarely in males. The male variant is the social personality disorder. So the people who you are most likely to see in prisons, that's the male version. So it's probably defined by emotional instability. That's the main feature of it. And it's very disruptive to everyone's life. They can be depressed as well. So it's important to cover that mood part when you see them as well. And probably substance abuse, alcohol abuse, because they do that as well. But actually, I think I without knowing about what could be, you've asked a lot of really good questions. Like, I think you've asked, what would you do if you were to leave the hospital? This is a really good question. I do ask the same question all the time. And it was good to go and explore a bit about the life situation, kind of living arrangements. Because obviously, if you have someone who lives on their own, they're more kind of risky than if they live with family that can stop them from self-harming / kill themselves. Yeah, I think as Samantha mentioned, probably these kind of patients are very hard to handle just because they're emotionally unstable. So you need to be very gentle with them, and kind of try to be very kind and empathetic with them when you ask the questions. So with a patient that's highly psychotic or manic, we didn't have a manic patient, but they're kind of similar in a way. you can be a bit more blunt because you want to stop them from their ranting. But with this kind of patients, maybe try to be a bit more gentle in the beginning, because you might find that they would close in themselves and they would stop talking to you, and then you'll be in a very difficult situation. So probably I would go and start with, okay, what happened and things like that, and I would emphasize more on things like, oh, I'm really sorry that you're in such a difficult situation. One thing I think I was in a way trying to do that as well. Don't necessarily try to come up with solutions in an interview or during the interview, but rather kind of focus on the interview and then maybe discuss about solutions in the end rather than that, because it seems that you want to pitch a solution, which is natural. It's what you naturally want to do. But for the patient, it might feel that you don't actually listen to them. So probably that's the only thing that I would say. But otherwise, a lot of very good questions, bearing in mind that you had no idea about what could be the diagnosis. So well done. Do you have any questions?
No.
Right. Does anyone else have any questions?
I have one final question, I guess. I hope.
Yeah.
Can you tell us, I don't know, 3 differences between depression and this disorder? How can we differentiate them? Because they're very similar, at least for us in second year of med school, they are very similar.
They are, but they have some different features. With the depression, it's more kind of time limited, whereas with a personality disorder, it's something that the patient has been experiencing throughout their life. Depression, you rarely see self-harming, but rather attempts to end their life. Whereas with personality disorder, you see a lot of attempts, well, a lot of self-harming, overdoses, things like that. And the most important thing is that there is a lot of instability pertaining to relationships, which you don't see in depression. So they will usually change their partners frequently, change their jobs frequently. Then they would rarely describe being low all the time. They would describe, my mood is all over the place. I can be happy now and very sad in 1 hour's time. So they would rarely say, I'm sad all the time. They are kind of up and down with their moods throughout the day. So this is kind of a main difference. Someone who is depressed is depressed all the time. They won't be feeling good now and sad in 1 hour time.
And what treatment would you recommend regarding this condition? What with?
That's a good question. If I would know the answer to it, I would probably be richer than I am. I think the only recommended one is dialectical behavioral therapy, DBT, which is focused on the here and now. So basically giving them skills. I think one of you asked about, can you think of something else that you can do to cope with this? I think you have asked this. So basically DBT deals with this, giving them skills to do something else when they feel the urge to self-harm or try to kill themselves. DBT is more kind of dealing with their emotions, mindfulness. So it's not a treatment in itself, but it's more how to deal with it. Medication is not that helpful if they don't have a comorbid condition. Like they can be also depressed. I mean, no one says that they can't be depressed. They can be depressed. And that's basically it. Interesting fact is that it usually fades away. It usually fades away when you start to age. So you rarely see old people with personality disorder.